So it's a little difficult topic actually, extended indications, because indications for unis have been defined. Dr. Yash has already almost covered up my topic, I think. So everybody knows by this what are the indication for enteromedial disease. We can do uni, bone on bone, ACL should be normal, MCL should be there, lateral compartment should be healthy. So I think controversy regarding these things, PF joint, patellofemoral joint, obesity, age or activity level. So I'll try to cover up these things. Why we need to apply so many of our brains? We can simply do total knee and get off. So it's because of these reasons. Low morbidity, early recovery, less complication, excellent results actually. Forgotten knee is really seen in UK. Either patient fails, if it is successful, it's forgotten knee. I'm very sure about it. And almost equal longevity. Most of the patients behave like this. I'll just rush through the slides. You can't get in total knee all these things, I think. This guy, he was not able to walk. Now he's running up and down the stairs. He has never come back for the follow-up. My team calls him up every year. Sir, are you fine? He says, I'm running. This lady, can you see the pivoting? Bilateral Oxford. This ACL with uni. This guy, he is into skiing. He is so active. At 1 week of the surgery, he is 73. So ACL is little controversy. If it is totally healthy, definitely we can go ahead. If ACL is not intact, either we can reconstruct the ACL with uni or we can repair it. Like this lady, she had pain on the left side, but she doesn't want total knee because she was very, very active. So we planned for uni ultimately, but during surgery we saw that ACL is not fully intact. There were partial tears. So we augmented and reconstructed the ACL along with the uni. So in these kind of patients who want uni, he don't want total knee at all, want to be very active, yoga, everything, we need to think about these kind of patients. Then patellofemoral. As recommended, all these fall in the criteria for uni and this doesn't. I'll show the x-ray of patient. This is a person with the left knee pain and see the skyline. Apparently it seems that lateral compartment is not healthy in PF. I'm talking about the patellofemoral. And see, actually, this is medial side gone, but lateral was very healthy. Ultimately we did Oxford in this. So age, as Dr. Gulati told, for elderly it's a very, very nice thing. Elderly are very, very happy, very less morbidity, and they are pain free almost within a week or 2 weeks maximum, we can say. We can save lives by doing uni as compared to total knee. Definitely we can save lives. This is the lady, you can see 64 age, quite bad knees. I think most of the people will think about the total knees. I've done it 10 years ago, bilateral Oxford. And you can see even after post-op X-ray, you can see lateral ossified, not very good lateral compartment apparently. But this is I think 2 weeks or 3 weeks after surgery. And the same lady now 10 years after surgery, hale and hearty. Then obesity, in obese patients, still we can do, I think it is, complication rate is much, much less in uni as compared to total knee. If we can do total knee in any obese patient, we can definitely do uni. High BMI patient. This was interesting. She was actually a gynecologist. You can see bone on bone is on left side and right side not bone on bone, but she had pain only on right side, no pain on the left side. She was insistent upon that I need bilateral surgeries and uni because I want to be active. I was not for surgery on the right side. Finally, she got the MRI done. MRI showed, you can see ACL tear on the right side, which was evidently better knee, and intact ACL on the left side. We opened up. I offered her HTO, but she was obese, one thing, and other thing, she didn't want the HTO. And actually, MRI was seeing complete tear of ACL on right knee, but ACL is well intact on right side. It was torn on the left side. So ultimately, we had to do total knee on the left side. She is the one. Bulky legs, female with the bulky legs, yeah. Same, it's I think 7 or 8 years ago we did it, and she's still fine. And elderly, this is the X-ray of my mother. I did this side 3 years ago. This is the latest one. Why I'm showing this X-ray? Because I want to say, in elderly, normally we think osteoporotic bone, it will sink. We can take very less tibia cut. If someone is doing uni, I can tell them how to do that. Very, very thin, just 0 mm or 1 mm of tibia can be taken, and then you can find a very good sclerotic bone. Can you see how proximal tibia is? And she was in kitchen, she made aloo pranta for me on day 5. And this lady, this was my second patient when I operated in July 14, and still she is running around. So uni is for all these things, but we can definitely extend the indications, and we can get these kind of results. I firmly believe that it's a surgeon who fails. The cases I've done around 600-700, total around 8 or 10 failures till now. Now I see the past, it was my failure as surgeon, not the surgery it failed, because it was poor planning or execution. Thanks a lot.